All right. Welcome to Friday's lecture. And this one is going to be on beta agonists. But let me start by just helping you place the context of this lecture. And I'm going to go back as far as this, where um, we went over this graph, talked about this in two other lectures, went over this in some detail. And stressed its importance in how this was the original cardiovascular data that helped define an alpha response and a beta response and led to the supposition that turned out to be correct that there are alpha and beta receptors. And I showed another cartoon model of essentially the same data. You might spend some time, go through this carefully, and make sure you understand the message here, that the alpha effect is mostly a vasoconstrictive effect, which is seen in this part of the graph over here, right, and is displayed as an increase in peripheral resistance that's provided by constricted blood vessels, and a reflex, even names it up here, reflex bradycardia that's baroreceptor mediated. The proof of that is on the next slide. And the beta effect shown in the third panel, which is mostly manifested as an increase in heart rate, shown here, and an increase in pulse pressure, and a big decrease in vascular resistance, which means vasodilation, which turns out later we found it was a beta 2 receptor mediated effect. And here's the evidence that shows that reflex bradycardia is shown right here, that the reflex bradycardia is indeed a reflex, right? You should understand the logic of this graph, what's being shown here. It is the blood pressure and heart rate response to an injection of phenylephrine before and after mecamylamine, which is a ganglionic blocker. Sorry for the bad handwriting. Ganglionic blocker that blocks the nicotinic receptors in the autonomic ganglia, thus preventing any reflex responses from reaching the organs. So the pretreatment with mecamylamine, followed by the injection of phenylephrine, still causes the direct effect of an increase in blood pressure, right? And so that is an alpha receptor mediated effect, alpha 1. And there is no reflex change in heart rate shown here. And so that demonstrates that the mecamylamine blocked the change in heart rate, and indicating that was a reflex effect. All right, so I summarized those slides and talked a little bit about the differences in beta 2 receptor activation versus alpha 1 receptor activation on blood vessels, right, on the skeletal, on the smooth muscle, smooth muscle that surrounds the vasculature. That beta 2 receptor activation results in relaxation and vasodilation, and alpha 1 receptor activation results in constriction or contraction of the smooth muscle, and we call that vasoconstriction. And so these are both receptors. The beta receptor responds to epinephrine and norepinephrine, and so does the alpha receptor. So it's kind of wow. So you get opposite effects by the same compound acting on two different receptor populations. And yeah, you do. And it's a dose-dependent effect where the beta receptors are activated at lower doses and the alpha receptors are activated at higher doses. And that's what's shown on this graph right here, is that as you increase the dose of norepinephrine, you first get a beta 2 response, which results in relaxation of the smooth muscle, right? Relaxation of the smooth muscle and the vasculature. But as you increase the dose, further increase the dose going this way, then you start to see the beta effect, right? And expect to see some figure like this on the test, right? And so then we talked about neurotransmitters as drugs, right? And so these would be called direct acting agonists. And the neurotransmitters, epinephrine is a drug. It comes in a bottle, right, available for injection. and it has these various properties. Most notably, it causes vasoconstriction, right, which will raise blood pressure, but it also causes, will activate beta 1 receptors as well at higher doses, and that seems to be in conflict with what I just said on the previous slide about how the beta receptors are activated at lower doses, where you have to remember that there is a reflex decrease in heart rate that begins with a vasoconstriction, and to see the actual beta effect, you have to push the dose higher. I hope that makes sense. It does to me. Epinephrine is a useful emergency drug, and norepinephrine is not so useful as a drug because when you cause a lot of vasoconstriction and increase the output of the heart at the same time, then that puts a lot of stress on the heart. So it tends to be a little bit of a dangerous drug. Epinephrine is considered a workhorse utility emergency drug used in the treatment of shocks and cardiac emergencies and asthma emergencies and other conditions as well, I'm sure. And you'll learn more about that in your clinical classes coming up. And that it's also used as a local anesthetic to keep the locals local. And then we talked about dopamine as a neurotransmitter drug, and like the other two, this one also comes in a bottle ready for injection. Can't take it by mouth because of the COMT that lines the intestine will digest it or metabolize it to an inactive compound. But this is a drug that's used in cardiac situations where there's something wrong with somebody's heart. It could be a variety of conditions. Most notably, I would say it's congestive heart failure. Dr. Stewart will be giving you the details on this later. And at this point, you need to know that it is stimulatory to the heart, where it seems to activate beta 1 receptors on the heart, and it stimulates norepinephrine release, and those will activate beta receptors on the heart. And a notable feature about dopamine as compared to epinephrine or norepinephrine is that it improves renal blood flow, and this can be an important thing in congestive heart failure because the kidneys are sensitive to the loss of blood flow. So this opens the vessels that allows blood to perfuse into the kidneys more easily. It increases glomerular filtration rate, as you would expect with an increase in blood flow to the kidneys. And this effect is probably mediated through dopamine receptors or dopamine 1 receptors mediate this effect. And so that's an important consideration and kind of a little pearl to remember as we as you go forward with your education. All right, and so the next drug on our list would be a drug that's not used clinically that I know of, but it's historically an important drug, is isoproterenol. This was the drug that was used to define the beta effect in the graphs that we spent so much time on, isoproterenol. This was the first compound that was invented that was considered to be beta selective. Now, it's not selective for beta 1 or beta 2. It activates both beta receptors. And because it activates beta 1 receptors on the heart, we call it a cardiac stimulant, and that is it produces inotropic, chronotropic, and positively dromotropic effects. You should know what those words mean by now. And it also activates beta 2 receptors, and the predominant effect of beta 2 receptors we see is vasodilation and bronchodilation, which means that this could be good use for asthma. And both of these effects are good in some clinical situations, but not necessarily at the same time. You wouldn't want to give somebody an asthma drug that stimulated their heart, right? So therefore, it's not, I don't know that this drug has a place in therapy, but again, I'm not a clinician. They'll tell you the truth. But it is considered the prototype for a non-selective beta agonist. All right, but not selective for beta 1 or beta 2. The only thing that we've got that we could say that might be beta 1 selective is that the dopamine is a little bit beta 1 selective, but it also stimulates beta dopamine receptors, so that's not really true. And then we have this drug, right? And I listed this drug as a beta 1 agonist, and the drug is dobutamine. As the generic name, the brand name is Dobutrex. And it's uh, partially true to call this drug a beta 1 agonist, but for the purposes of our exam, we are going to call it that. It's got a really complex pharmacology, and that this drug preparation has D and L stereoisomers, right? It's a racemic mixture of the dobutamine molecule, and the two different stereoisomers have really different effects. One of them stimulates beta 1 receptors and antagonizes alpha 1 receptors, and the other one stimulates alpha 1 receptors. And so the alpha receptor effects kind of cancel each other out. Though it's active at alpha 1 receptors, you don't see that effect. You can, if the doses go up, you'll start seeing some alpha effects and vasoconstrictive effects, but usually you expect not to, because the primary effects of this drug are at beta 1 receptors, and it's used in the treatment of congestive heart failure and other cardiac conditions to increase cardiac output. Now, a little more detail with this, and this is important for you going forward. It has more inotropic effect than chronotropic. In other words, this drug increases cardiac output, mostly by increasing stroke volume. Not heart rate. All right, and in truth, that's what you see with selective beta 1 effects. The other drugs like epinephrine will also increase heart rate, and that's because epinephrine is probably acting on some beta 2 receptors on the heart and some alpha 1 receptors on the heart, which we haven't talked about yet, so don't worry about that as too much detail. But do remember this next sentence right here, that it's more efficient to increase cardiac output by increasing stroke volume than it is by increasing heart rate. And other words, you could say, it's, what do you mean more efficient? Well, the amount of oxygen that it takes for the heart to increase cardiac output by increasing stroke volume is less than the amount of oxygen that it takes to get the same increase in cardiac output by increasing heart rate. So this is really easier on the heart to increase cardiac output by increasing stroke volume than it is by increasing heart rate. And that's a little clinical pearl that may be worth hanging on to for the future. So, I'm going to try to remember to ask a test question specifically about that. And we shouldn't ignore the fact that I put the structure of this drug up here, and this much of the molecule is dopamine, right? And this would be considered an R group. Right? It's just an add-on to dopamine. So, and I probably won't ask you about that, but I did want to point it out. All right, so now we're going to turn to another class of drugs, and these turn the page, different subject here, because now we're talking about beta 2 agonists, right? And there are several drugs that I've listed here that have pretty selective, not perfectly selective, but predominantly selective agonist effects at beta 2 receptors. And these drugs are used in treating asthma and chronic obstructive pulmonary diseases. And you may not know, but I have tracked this data right here for a while. And the last time I saw it updated was in 2013, where in the United States, 3,630 people died from asthma attacks. You might not have thought that asthma, because you probably know somebody that has asthma, that it would be such a potentially deadly disease. And there are people that die from this. So I just listed four drugs that are beta 2 agonists, and this is only a partial list. There's many drugs in here that are beta 2 agonists that are used to treat asthma and chronic obstructive pulmonary diseases, because those are chronic diseases, long-lasting diseases, and a lot of people have them. And the drugs are albuterol, right? So if you see albuterol, you should know that's a beta 2 agonist. Terbutaline is a beta 2 agonist. Salmeterol and formoterol, right? And I superscripted the albuterol and the terbutaline with a 1 to indicate that those are short-acting drugs, and salmeterol and formoterol are long-acting drugs. And you should know the difference between those two. So you need to be able to recognize these names as being beta 2 agonists that are used predominantly in the treatment of asthma and chronic obstructive pulmonary diseases, and that the first two, albuterol and terbutaline, are short-acting, and the other two, salmeterol and formoterol, are long-acting drugs. There's another drug in this class, ridodrine. I don't know that this has widespread clinical use, but it is considered as a beta 2 agonist, and it's called a tocolytic drug. And that word, tocolytic, means that it's used to prevent premature labor, right? So if a woman is expecting and she goes into labor and it's considered, it's not really the best time, can we prevent the labor? Then yes, this drug might be a choice for doing that. Now, is that actually happening in the clinic now? I don't know. I don't keep up, but historically that has been the truth. These drugs collectively have some adverse effects, and that is that they may have some effect on the heart, right? Because they're not purely beta 2 specific, and may cause some arrhythmias. They may cause a reduction in plasma potassium levels, which is dangerous for somebody with a heart condition. They may increase blood glucose levels as well, right? Which will be important for somebody that has the disease of diabetes, right? And they do that because they all have at least a little bit of beta 1 activity. I put the structures down here at the bottom going in the same order that they're listed here. This is albuterol and terbutaline, and salmeterol and formoterol and ridodrine. Right. So there's 5 drugs for you to know and some very cursory facts to know about those drugs. More of what we're seeing in the treatment of asthma and chronic obstructive pulmonary disease are drugs like this one. This is Anoro Ellipta, and there are many variations that are coming out on the market that are combinations of drugs. And this is the product name, and it contains 2 drugs. One is umeclidinium, this drug right here, umeclidinium, which is an anticholinergic drug, and this is a muscarinic receptor antagonist, right? So this is a muscarinic antagonist. And we covered those earlier. You might remember ipratropium and tiotropium that were used in the treatment of asthma and chronic obstructive pulmonary disease. This is a muscarinic antagonist like those other 2 drugs. And it contains, that's one product, and the other drug that it contains is this bilanterol, which is a long-acting beta 2 adrenergic agonist. And you'll see long-acting beta 2 adrenergic agonists in the literature as LABAs, right? And this this product is indicated for the long-term, once-daily maintenance of airflow obstruction in patients with chronic obstructive pulmonary disease, and I emphasize not asthma. And that is an important feature that's fallen out of the long-term use of these drugs on large populations of individuals. What we see is that survival rates are actually lower with the use of this drug when it's used to treat patients with asthma as compared to other drugs. So the actual, the likelihood of dying from an asthma attack is slightly greater in patients that use this drug. So it's not indicated for use with asthma, but it is with chronic obstructive pulmonary disease. This doesn't mean, I'm not saying that it wouldn't work with a patient with asthma. It would It's just that for long-term use, that it tends to be more dangerous and is certainly not approved for that. And I added a little note down here that these long-acting beta agonists, the LABAs, the long-acting beta agonist drugs show an increase in patient mortality when used in the treatment of asthma. And I alluded to earlier the fact that historically we included asthma as a chronic obstructive pulmonary disease, and this is a type of event that fell out of our findings of long-term studies of drugs that said you need to be separating asthma away from chronic obstructive pulmonary disease because the drug therapies show different effects. So Arono, Ellipta, combination of umeclidinium and bilanterol. And there are many other products that are out there that are similarly combinations of anticholinergic agents and long-acting beta agonists used in combination. And what else have I got here? Here's another combination drug that is popular, the bilanterol again, the long-acting beta agonist used in the product Brio, and there are several variations of this product, and it's combined with fluticasone, which is an ICS, which is an abbreviation for an inhaled corticosteroid. So this product, Brio Ellipta, is a once-a-day product used in specific patient populations that have obstructive lung diseases. And I put the warning for this on the next slide just to emphasize the truth of it right here. And let's read through this real quick. That this has, in recent years, has been new information, and it's like, clinicians using these drugs need to be aware of this fact, that long-acting beta-2 adrenergic agonists, LABAs, such as bilanterol, one of the active ingredients in Brio, is increase the risk of asthma-related death. And that's just a finding that came out by studying lots of people taking the drug for longer periods of time. A placebo-controlled, right, meaning a non-active drug, controlled trial with another long-acting beta agonist, salmeterol, which was on the first of these drugs that we looked at, showed an increase in asthma-related deaths. This finding with salmeterol is considered to be a class effect for all long-acting beta agonists. Currently available data are inadequate to determine whether the concurrent, that means two drugs at the same time, used simultaneously, whether the concurrent use of inhaled corticosteroids, ICSs, with other long-term beta asthma control drugs mitigates the risks of asthma-related deaths with LABA. Available data from controlled clinical trials suggest that LABA increase the risk of asthma-related hospitalization in pediatric and adolescent patients. When treating patients with asthma, only prescribe Brio for patients not adequately controlled on long-term asthma control medication such as ICS or inhaled corticosteroid, or whose disease severity clearly warrants initiation of treatment with both an inhaled corticosteroid and a long-acting beta agonist. In other words, you better be able to justify the use of these two together, and it needs to be an apparent and important use. Once asthma control is achieved and maintained, assess the patient at regular intervals and step down the therapy, that is, discontinue the Brio, if possible without loss of asthma control, and maintain the patient on a long-term asthma control medication such as an inhaled corticosteroid. Do not use Brio for patients whose asthma is adequately controlled on low or medium dose inhaled corticosteroids. So I put this up here just to show you where you're going in your education. And I'm not going to put this on the test, but I want you to be aware of that this is the level of detail and the type of clinical information that you're going to expect it to be very familiar with by the time you finish our program. And I thought, well, you need to start looking at it now. All right. one other drug. This is, I think, the only beta 3 drug, and this is, I see this one advertised on television. So it's mirabegron or Mybetrix, which stimulates beta 3 receptors. And this is another one of those drugs that is used to treat what we call overactive bladder. And we saw this similarly with drugs like Detrol or oxybutynin, etc. So we've already seen this treatment arena before, but here's a different class of drugs that where the drug that's being used is a beta 3 agonist. So its effect is to relax the detrusor muscle of the bladder. That's the wall muscle. And it's used in the treatment of OAB, or overactive bladder. Don't you just love some of these abbreviations? Which causes frequent and often unwanted urinations. Interestingly, beta 3 receptors also mediate lipolysis, and that is, they cause the fat cells to start breaking down the stored triglycerides, and they may activate what are called uncoupling proteins. And this is kind of a tangent, but it's an interesting one to me. The uncoupling proteins are a set of mitochondrial proteins that burn fat to generate heat. So it's like a potential mechanism for weight loss without exercise, right? And uncoupling proteins. Be looking for drugs that target this in the future. Uncoupling proteins. All right, uncoupling proteins burn fat for heat. Wouldn't it be convenient if you could just take a drug that would start burning your fat off and you didn't have to work to do it? Burn fat for heat. Might raise your body temperature a little bit. All right. And they may cause relaxation of the prostatic smooth muscle as well, which these imply what? Well, at this point, future drug use. Future drug use. All right. And prostatic smooth muscle is a problem in older men that have enlarged prostate glands that have difficulty urinating. So in that patient population, you may see a positive effect for a drug that produces the opposite effect in a different patient population. But I'm not going to put that on the test, but you need to be aware of this stuff going forward. You need to get a good education. And a little bit of a shortened slide set today, but I think that'll do it. Hope y'all have a good weekend, and hope you did really well on that test.